let me introduce our next speakers, who is Professor Joseph Wallen, another friend of ours. And so Professor Joseph Wallen worked with us in the CHK AEMAU for 2 years, and he has recently returned to the United States. So I must say I'm really, really happy to see you well again today. And Professor Wallen has extensive experience and connections with EM colleagues in mainland China, Taiwan, and the United States, where he completed his specialist training in emergency medicine. He is now an associate professor at Penn State University in Hershey. He's going to talk to us about ultrasound training today, and I'm really looking forward to that. Professor Wallen, please.
Yeah, thanks so much, Alex. Can you guys hear me okay?
Hello. So nice to see you again.
It's actually great to see you guys too. I know Hong Kong's been through the ringer with COVID, much like the US has been the last 2 years. I guess everyone suffers in turn, it seems. And now I guess Shanghai's really in the news as well. But yeah, thanks so much for the invitation to talk to everybody about ultrasound and the emergency medicine curriculum. So, yes, let me just pull up my slides here. All right. Okay. So, for better or for worse, I have nothing to disclose. No one has given me money for any of this. Just as a quick review, my own personal background and why I'm talking about this topic. The purple circles are all the places I've worked at in the US. And just as a background, this talk is really going to be very practical and really based on my own personal experiences over the last 20 years of really teaching ultrasound, first learning ultrasound and then actively teaching it. So the first place I was at for my residency was here in New York City in Queens at this fine hospital. And just a quick shout out to my ultrasound teacher, Dr. Ladner. Yeah, she was great and really took the time to very patiently teach me all about bedside ultrasound. There we have a nice ultrasound machine there in the background as well. After graduating from residency in the US, it's a set 3-year program, occasionally 4 years, but most are 3. I went with my family to St. Louis, Missouri, right in the middle, to this hospital. And St. Louis is known for its trauma, actually. It unfortunately, again, for better or for worse, has just an inordinate amount of penetrating trauma, as well as high-speed trauma. So, for example, whereas in New York, I honestly don't think I ever saw like a positive fast scan. In St. Louis, there was at least a positive fast scan every week. So just a completely different practice environment over there. So yes, lots of trauma. And then on the completely other side of the planet, like Alex said, yeah, I've been at CUHK for 2 years and recently moved away. But as we know, Hong Kong does not really have much penetrating trauma. It definitely does have some trauma though, so it's relevant. And so I'm currently at Penn State. So Penn State is actually, the main campus is separated from the medical campus. And I'm at the medical campus, which is in Hershey, Pennsylvania. And that's the same Hershey as this famous chocolate company. I think you can find it in the stores in Hong Kong too, actually. Unfortunately, our hospital is not made out of chocolate. This is the hospital I'm working at right now. It is funded by the Hershey Corporation. So the chocolate company gave a big chunk of money to the state to start a medical school and hospital in the company town. So this is located very close to where the chocolate is made, but yeah, unfortunately, it is not chocolate inside. So today I'm talking about ultrasound specifically in terms of training and emergency medicine training at that. And I really want to emphasize my own personal experiences and what I feel are challenges, controversies, and also the positive aspects of bedside ultrasound. So at this point, Ultrasound really has become a key part of emergency medicine practice. It's now routinely used worldwide. In the United States, it's used at all level 1 trauma centers, and actually a lot of smaller hospitals as well. In fact, out of the about 10 hospitals where I've worked at in my life, there's only one that did not have an ultrasound machine in the ER. So the machines have all been located physically in the emergency room. There was one it was a very small ER in rural Missouri. It had 4 ER beds and no ultrasound. But another evidence of the growing import of ultrasound is now the FAST scan is part of ATLS guidelines. So when you renew ATLS in the States, you have to kind of know what FAST is about. And if you want to graduate from emergency medicine residency, you also need to train in ultrasound. So just a quick review of the short history of ultrasound in emergency medicine. It really started in the 80s, where researchers in Asia and Europe, primarily Japan and Germany, but other countries as well, started looking at ultrasound for trauma patients. And the famous FAST scan grew out of this research and really replaced the DPL. Now, I'm not sure about the audience, but personally, in my 20 years as an emergency medicine doctor, I have only seen one DPL, and it was very interesting. I don't think it actually changed much at the time, but yeah, so only one DPL that I've ever seen, as opposed to thousands of FAST scans. So now, really, FAST scan is the initial radiologic exam that we do for trauma patients when they come into the emergency department. And as FAST has become the standard of care, it's shifted into basically mandating that we need to teach our students how to do it. And actually, so FAST was the keystone and the initial lever that leveraged ultrasound into academic training programs based on the necessity of needing to know FAST. All the other ultrasound scans kind of piled on after that. So FAST was the initial lever into it, and then everything kind of came from there. Just briefly, I think we all know that the hope and dream of bedside ultrasound in the ED is that we can acquire the images ourselves, interpret them at the bedside, and then rapidly put them into the management plan. As opposed to traditionally where we order a scan, that order has to be transmitted, received, acknowledged. The patient needs to be transported over to the ultrasound area. And then you have to wait for the radiologist to read the images that are acquired and transmit or call if it's really what they feel as an emergent finding is transmitted to you. Just on a practical level, I've noticed personally that whenever I try to order a traditional ultrasound in an American ER, I often have to talk to the ultrasound tech because, for example, I want to rule out a cholecystitis, for example. So I'm interested in the gallbladder. So I put in right upper quadrant ultrasound, and then invariably the ultrasound tech will call me back and say, "No, doctor, that is not the right order." Great. So I have to have this kind of grinding the gears where what I want to happen and the ultrasound techs know and can slot that into their own predefined categories has to kind of mesh. So for example, they'll often want a complete abdominal ultrasound or other kind of slightly different wording. So there's that just a practical issue there. As opposed to bedside, where I know what I want, I can do it. It's very straightforward. So beyond that, there's also some public and economic pressure on getting patients through the ED faster. I think we all know that. That's been an issue around the world. Unfortunately, I feel like we're losing the fight. It just feels like, if anything, patient flow has been slowing down for the last 10 years. Definitely in the US, unfortunately. I know patient flow was an issue when I was in Hong Kong as well, and in mainland China for sure. So the hope by moving ultrasound to the bedside and having emergency medicine doctors do it is we could save, theoretically 90% of the time and get people through much faster. To be honest, I'm not sure if this has been realized, but I'll talk more about that later on. So just again, the brief timeline. So in the 80s was when a lot of foundational research was done on FAST. In the 90s is when the FAST was then leveraged to incorporate many other studies that were relevant to emergency medicine. And in 2001 is when ACEP actually set a scope of practice guidelines. So this is really when people started taking notice. And then about a decade after that came the expansion for more studies. But arguably more important was the consensus guidelines for emergency medicine resident education. So the reason why this was important is because it actually set numbers to required ultrasound studies that residents needed to do to graduate. And actually, these numbers have not changed. They have been in effect for almost 15 years now. So just to kind of drill down into this a little bit more, 80 hours of dedicated clinical ultrasound. Now, emergency medicine residents in the US tend to do about 40 hours of clinical work. So this translates into about 2 weeks of full-time scanning in the ED. The way this works practically in a residency is that emergency medicine residents will often they'll have a month-long block, so 4 weeks, and they'll either do 2 weeks of anesthesia and 2 weeks of ultrasound, or 2 weeks of research, or 2 weeks of something, and then 2 weeks of ultrasound will be kind of smashed into that. Sometimes some programs try to combine anesthesia, usually, with ultrasound, because the resident can go in 6 a.m. when all the surgeries start, and do some intubations in the morning, and in the afternoon when really the OR is kind of slowed down, they can shift back to the ER and do dedicated scanning. So that's typically how it works, just on a practical basis. So I would say that's pretty easy to achieve as long as there is structured ultrasound time. The 20 hours is also relatively straightforward. What it comes down to is about 1 to 2 hours of dedicated didactics every 1 to 2 months. And over 3 years, you hit the 20 hours of dedicated ultrasound education. So again, not too hard, as long as the program has at least one, hopefully more than one, professor, doctor, or attending who likes ultrasound and can lecture on it. That's usually quite achievable. And then we come to the probably the most famous part is the 150 scan. So this is the target. This is actually the target when I was a resident back at New York Hospital Queens. I graduated in 2009, so this is actually, it became official right when I graduated. But my teacher, Dr. Ladner, who you saw her picture before, she came in saying, we're going to do this. And all the residents were required to do 150 scans at least. Now, it was just 150 scans. There was no subdivision beyond that. And I want to be clear, this is currently the national standards. So if you go to any of the 200 plus residencies in the US, these are the standards that they go by. Now, when I was in St. Louis, I'll get that to the next slide, but just as a quick overview, there are 221 EM programs, and about half of these at this point have ultrasound fellowship training programs. This is an optional extra year that residents can do. And the ACEP guidelines for this, you can tell, are much higher. You have to do 1,000 scans, and you have 20 hours at least dedicated to ultrasound every month. Now, on a practical level, and we can get into this with Q&A later, but the fellowships in emergency medicine in the United States are very niche. What I mean by that is residents tend to do that. In the minority of cases, they have a genuine interest, and that's fine. To be brutally honest, I think people tend to do fellowships if they want a job. So if you're trying to get a job at a very competitive part of the country, so California, Seattle, probably Washington, D.C. are some of the most competitive areas to try to get a job in. And that's just geographically. Oftentimes they'll try to do a fellowship in a residency program in these places to leverage that into a job. And I'm happy to talk more about that later if you like. Now, when I was a resident, that was still early days, so there were very few places that actually had ultrasound fellowships at them. Interestingly, where I trained, the very last year, of my residency, they actually started in ultrasound fellowship. So I kind of could see the transition and the pluses and minuses of programs that had dedicated fellowship programs. So this is from the perspective of a residency without a fellowship program. So from my perspective on the ground, I found that actually the residents got more dedicated time from the faculty when there was no fellowship. So Dr. Ladner, she became the fellowship director, and once she did, she really dedicated her time to the fellows. So then the fellows were then the ones responsible for teaching the residents. So you can kind of get the idea when you have kind of the sub people involved in teaching you versus the the top person teaching you. I could definitely feel that teaching it had a bit of a fall off. Now, on the other hand, there are some positives to being a resident at an institution that has a fellowship. So basically, if you don't have a fellowship, there are just fewer faculty in general. You don't have the fellows. There are probably fewer dedicated ultrasound faculty because a fellowship needs at least one, but honestly, they usually have 2 to 3 who are really dedicated to ultrasound. And these fellowship programs, they often have a very clear and robust quality assurance process, essentially reviewing the images and giving feedback. So that's a rather time-consuming thing that places that don't have a fellowship are not very robust in. So getting good feedback is actually, honestly, that is very helpful for learners. So that is found more with a dedicated fellowship. And then places that don't have a fellowship, you could say they're less cutting edge. There's really no research program per se. So they you may not be on the leading edge of ultrasound activities. So again, just on a very practical basis, what does this look like on the ground? So in my residency, again, I had the 150 studies target. So that was what I had to do to graduate. When I went to St. Louis, I was in charge of teaching ultrasound. And what I did was a little bit of a slight rift on that. So again, 150 studies, I was totally fine with having that be the target. And I didn't really go any higher than that. I think 150, actually in my almost a decade of doing that in St. Louis, I feel like 150 actually was honestly a very, I felt like most residents could handle that quite well. What I did do though was I brought in this 10 in 10 core subjects, and you can see there in the first bullet point there from fast onwards, those 10 subjects, I had the residents do at least 10. So in my residency, I know there are some residents who kind of could play the game, and they did not 100 fast scans, but they were very very unbalanced, let's say. So to try to fight that imbalance, I had the residents do at least 10 of each of these core subjects. You'll notice that 10 is more than the ACEP core 7. That was always a debate, which things I want to do 10. I think honestly, the 10 of 10 just is a nice round number. So it was good for the residents to remember. I pulled out ocular and soft tissue, even though they're actually very good scans, just in the interest. At the time when I first started it, they were still pretty early, and ocular was a little bit more intensive to do. So just the interest of time, I pulled those out as more optional. Now here at Penn State, just for another comparison, it's again 150 scans to graduate. What they do here is they have more of a recommendation of doing 25 in the ACEP 7. So you see the 7 there. And again, it's recommended. So if you do 7 times 25, that's not 150, that's 175. So it's not a hard rule. It's not a mandatory rule, but it's a strongly encouraged rule. So I think that's fine and that's interesting. You can kind of see they pull out the 4 that were added in 2009 as more optional. So again, that's debatable. I personally thought thoracic and DVT were pretty important for standard emergency medicine practice, but hey, that's just my opinion. So When it comes to actually teaching ultrasound, kind of the downside is that it's unfortunately quite teaching intensive. Just like what Ralph was talking about with simulation, it's it just takes a lot of one-on-one time. It's basically procedures, and you really have to do it in person, and it's just a lot of time. And so how did this work, again, on the ground? So what I did in St. Louis when I was in charge of teaching ultrasound was I had a once-a-year ultrasound workshop. And this is the case in Penn State too, where usually in July, July 1st is when the academic year begins for US medical students and residents. So we get the fresh batch of recently graduated medical students who come to the residency, and they are fresh. And nowadays they actually do know some ultrasound, but that's maybe in the last 5+ years. 15 years ago, most medical students had no clue. And just to be honest, when I started residency, I don't think I'd ever touched an ultrasound probe before residency. So the teaching is geared for just ground zero, a very basic understanding. And because of that, again, this takes time. So the way I did it was I usually would pick 2 topics, and I would give a 45-minute didactic or just a lecture on those 2 topics, and then just go right into 45 minutes of workshop. So hands-on teaching. And what I would do is I'd set up several stations, depending on how many machines we could pull out of the ER and how many attendings could help me out. And each of us would stack a table and then have the med students and residents in attendance go around each station and take turns doing those 2 studies, which I just lectured on. And then, so that is one set, and that's an hour and a half. And then we usually do 2 or 3 of these to make up the 5 hours. There's a regulation in the United States for residency programs to have 5 hours of direct education every week, and that's a national mandate. So this actually fulfills that. So the residency program director is actually very happy about filling the time. But nowadays, there's so many topics, that it takes at least 2 days to go through all of them, and really longer, because you want to have further episodes, later in the year, so the residents can keep on practicing and learning. All right. So one problem that I had in St. Louis was getting subjects. Now, that's actually less a problem in Penn State. They actually pay for people on the outside, like they're paid people to come and lie down and be our ultrasound simulation models. But in St. Louis did not have the money for that. So I had to bribe our medical students, basically just med students on the ER rotation. I said, well, listen, if you volunteer to donate your abdomens to science, I'll give you a copy of my ultrasound manual. And luckily, every year I did it, there were volunteers. So thank you to all the medical students who volunteered and helped us out. So beyond getting the medical students to volunteer, we also had a challenge getting the attending or professor positions to come and help out and teach. It's usually just uncompensated time. And one other issue that's been kind of growing as the years have gone on is medical students themselves want to know more about bedside ultrasound, as well as nurses, especially emergency medicine and critical care nurses. They're really quite interested, especially learning IV placement. And then APP here means Advanced Practice Practitioner. So they're the mid-level providers, so physician assistants or nurse practitioners. And they are also very interested. Frequently, they don't quite get, just with time constraints, they don't have the same training that the emergency medicine residents do. But there's definitely a desire on their part to learn. So, we can talk more about that maybe in Q&A, like how we fold in those, I'll call them non-traditional emergency medicine ultrasound learners. But yeah, that's been kind of an ongoing issue the last decade. So with the remaining time I have, I want to just touch on just some brief thoughts when it comes to teaching all the core ultrasound studies. Okay, so the first one is FAST. And like I was kind of talking about in the very beginning, most centers actually do not have many positive FAST scans. Now, there are models
Mm.
that you can do simulations on to kind of mimic that effect. Just the honest truth is, we can go through the motions of doing a FAST scan, but the first time a doctor actually sees a positive FAST, it can be quite surprising, and you kind of almost doubt yourself, like, wow, is that what I think it is? So unfortunately, it's very hard to have experience with positive FAST scans. Now, in general, that's true for most ultrasound scans because the positive patients are few and far between. But we do our best with showing videos, showing pictures, using models when we can. Um, but that's a challenge. So for first trimester pregnancy, for that one, again, it's, as you can imagine, very hard to model. You have to have willing female patients usually. So honestly, this one is done more just one-on-one in the ED between myself or other attendings with the residents to really get a handle on that. And it's tough because this one is probably the most difficult to arrange because of that need for one-on-one time. But arguably, it's one of the most helpful of the bedside ultrasound techniques. So yeah, I feel bad about this one, but that's the honest truth. It's tough to practice, but super important. The aorta, it's okay. It's tough because of bowel gas, but just with techniques of angling the probe to the sides, we can usually get around that. Cardiac, as the audience probably knows, there's a contention between the standard cardiology view, where the probe marker goes to patient left, and emergency medicine, where you have the probe marker for all the other studies go to patient right. So that's an ongoing problem. In general for cardiac, I try to have probe marker go to patient left if I actually am finding things that I want to talk to a cardiologist about, just so they're not weirded out. As we can imagine, when things are flipped, it can be very disorienting. And then I do want to mention that it's useful in cardiac arrest or code situations in terms of just ending them. Before ultrasound, we would often try to just keep pounding on the patient for a good long time. I've seen some codes run in Beijing, and I think they almost have like a mandate, like you have to code a patient for half an hour or something. It might have been hospital specific, but it's actually very, just to be, again, brutally honest, it's a big time save if we can call a code. If there's no hope anyway, if we can call it earlier. And then on the flip side, if we actually take a look at the heart and we see it in VF, if you see it fibrillating, I've actually seen it a few times, and that's great. You can just get on there and just shock right away, and you already have the gel, so it'll be good contact. But that's actually quite interesting when you see that. For biliary, that is technically the hardest one, I think, out of the batch, because it's just very hard to find the gallbladder, and then you have to find the CBD beyond that. So that's, again, technically challenging, probably the most challenging one, as opposed to urinary, which actually is pretty easy. The kidneys are part of FAST, finding the bladder is part of FAST, so not too hard. And then procedural, arms need to be sacrificed. So the reality on the ground is that IV placement is the number one reason we use ultrasound now in the ED. And residents, they're always dragging the ultrasound machine around because the nurses cannot get an IV on a patient. So they are the ones who are tasked to getting an ultrasound guided IV. And yeah, so you get a lot of practice. Unfortunately, there's a fairly steep learning curve to doing this. So some patient arms need to be sacrificed. There are models. I have yet to find a very realistic model. And again, we can talk more about this in Q&A if there's interest. Thoracic, actually it's easy to teach. I think it's actually quite interesting to teach lung ultrasound in particular. However, there are false positives, so its utility is, it's still an active area of research actually. DVT is also controversial because the desire is to use it as a rule out. So the way we used to use, or we still use, formal ultrasound orders to rule out DVT. However, that's controversial. If the physician has done enough exams and feels confident, it can be a rule out, but some people advocate for combining it with a D-dimer study as well. And again, that is controversial. For ocular, yeah, a bit of a pun, you can see many things. We have to have a cooperative patient. It can be a little messy, a little awkward, but can be a very powerful tool. And then finally, for soft tissue, initially I was a little dubious about this, but honestly, this may be the second most common technique I use on a daily basis in the ED for that rule out cellulitis versus abscess. You have a patient comes in with a red cellulitic area. It's tough to know if there's something to drain or not. So yeah, I guess in the interest of time, let me move things along a little bit so we can talk about this a little bit. I mentioned this, the reality of it is that ultrasound-guided IVs and then the soft tissue OB are the main studies that are actually done, even though there are 12 plus studies that we teach. And the essential controversies are that ultrasound's very specific, but not sensitive. So that is a challenge. So yeah, in the interest of time, let me cut to the Q&A session so we can get some thoughts from the audience. And just a quick shout out to all the places I've worked. These are some very useful websites. And then if anybody wants to drop me a line, here's my email. So thank you very much for your attention.
So thank you so much for Professor Wallen and for sharing your experience in the US. And I think it's really useful for us in Hong Kong because when I was a trainee and I did try to learn ultrasound and I was really interested in it. And but I find it hard because there was not much really organized course in Hong Kong. And also when I did an ultrasound, I don't know whether I have done it right or not because it's hard to find people to review. So, but I did learn from you and also Ralph, and so thank you. So, so what you have shared, I think it would be insightful, particularly for those educators in the ultrasound subcommittee who are listening right now here. So, thank you so much. And for the interest of time, we really have to move on. I think there would be comments and questions from the audience, but maybe you can ask Professor Walling directly by email, or maybe we can talk about it if we have time during the coffee break. I'm sorry, we must move on. Thank you so much, Professor Walling. Nice to see you again.
Thanks, everybody. Good to see you too.